Hey guys, it's Nicole Clark. Thanks for joining me for another edition of the Way Wednesday. Today I want to talk a little bit about ICD-10 coding, specifically coding the medical complexity of your patient, because that can really help to avoid an automatic denial. From time to time we see claims denied either by line or entire claims where we otherwise would think diagnostically we've supported the services. So for example, we have seen quite frequently, actually, and very recently too, speech therapy claims. Speech and language treatment has been billed. The therapist has coded Parkinson's disease, G20, as the primary and only medical diagnosis. The treatment diagnosis was cognitive communication deficit. So while on the surface, that would seem logical, right? Parkinson's would end up in a cognitive communication deficit and require speech and language services at some point within that disease process typically. And so it makes sense. So that coding on the surface seems okay. Well, in many cases, that claim gets automatically denied because the diagnoses don't support the medical complexity of the patient. And what I think these system edits are looking for are some additional medical diagnoses to support that cognitive communication deficit, because not every Parkinson's patient requires speech and language training. So what is it about your Parkinson's patient, your patient with Parkinson's, that actually requires that speech and language treatment at that point in time? So in addition to Parkinson's as your primary, which is a great primary medical diagnosis, you want to also think about coding another underlying condition. So do they have dementia as a result of the Parkinson's? Is that a consequence of the Parkinson's? If so, code that dementia. So maybe consider a code like FO 2.80, dementia and other diseases classified elsewhere without behavioral disturbance, or FO 2.81, the same diagnosis but with behavioral disturbance. Or maybe do they have dementia with Lewy bodies? So you might want to consider coding that. Maybe you could code something like I69.818, other symptoms and signs involving cognitive functionings following other cerebrovascular disease. So consider the complexity of that disease process and give us some more. Give them some additional medical diagnostic information to help support that cognitive communication deficit and the need for speech and language treatment. So for PT or OT, one of the things that we've seen from time to time get denied automatically is, for instance, when a therapist uses, say, back pain or low back pain like M54.5 or lumbago, M54.41 or M54.42, as a medical diagnosis, and then we're doing treatments such as therapeutic exercise and those kinds of things. Quite often that claim will get kicked out automatically as well, because again, we're missing the underlying condition of that back pain, right? So we also need to code that underlying cause. So is it osteoarthritis? Do we have spinal stenosis, scoliosis, or osteoporosis, something like that? We would also want to think about coding in our medical diagnostic information as well. Another code that we see get kicked out in line item denials quite frequently with some payers is self-care retraining. And, again, we're coding the way we feel like, we're supporting what we're doing. So in many cases, though, what we see is a treatment diagnosis of muscle weakness, and we don't really have anything else. We might have what we feel like are appropriate medical diagnoses, but the only treatment diagnosis we've used is muscle weakness. So we've talked a lot about including multiple treatment diagnoses when appropriate and encouraging the use of multiple treatment diagnoses just for this reason. So what else is there? Muscle weakness alone might cause some functional decline, but it may not require skilled intervention. Because remember, it's not that you're delivering the services that makes it skilled. The patient must have the level of complexity of their medical condition to warrant the need for skilled services. So it can't just be muscle weakness alone. We need to code that complexity of their condition. So, consider coding hemiplegia if that's present, or a lack of coordination or pain in a specific site, whatever that might be, to help support the complexity of your patient. And if you're doing that, you're going to be better supporting each CPT code that you build, the rug levels that you build, and your documentation as well. So I hope this helps. If you have any questions, please ask us below in the comment box. We'll get right back to you and we'll be happy to answer them. Thanks for your time, and I appreciate it, and happy documenting.